Good morning, everybody. It's really my great pleasure to be here in this gastroenterological meeting, and I would like to express my deep thankfulness to the Scientific Committee for more than kind invitation. My today job is to talk about the gallbladder stones and acute cholecystitis and the role of surgery, and also my task is to show you that surgeons have maybe more than 2 gyros in their brain out of this, one for the cutting and another for the suturing. So I have nothing to disclose. The learning objectives of my talk is to try to understand together how to make proper diagnosis. If it always looks like very easy, but if we have that failure at first step, then everything after will be for sure for failure. Then another task is to understand the role or the adequate staging of disease of acute cholecystitis, and also to understand the surgical treatment possibilities and other possibilities in the treatment of acute cholecystitis. So for beginning, I have my first question. What of the following is necessary for definitive diagnosis of acute cholecystitis? Is it abdominal ultrasound plus typical local signs? Is it endoscopic ultrasound or magnetic resonance cholangiopancreatography, abdominal ultrasound plus systemic signs of infection, abdominal ultrasound plus typical local signs plus systemic signs of infection, or just MRCP plus systemic? So please vote one of the which is the correct answer. Yeah, almost 100%. So that means that easy. And my next slide maybe is not necessary. Just a second. I don't know. Wait. May you repeat the presentation, please? Something doesn't function. Well. Okay, this is the slide which will explain that 100% of you was correct, that for definitive diagnosis we need to have the local signs of inflammation, we need also systemic signs of inflammation, and one of the imaging findings. And if we have just A plus B, then it's suspected diagnosis and definitive diagnosis. We need all 3 signs to have all 3 together to have definitive diagnosis of acute cholecystitis. So my next question is, what's the key difference between grade 2 and grade 3 acute cholecystitis? Is it presence of organ failure in grade 3, more severe findings on imaging modalities in grade 3, more pronounced inflammatory response, or palpable tender mass in the right upper abdominal quadrant, or presence of elevated bilirubin in the grade 3? Yeah, this is almost 80% of you. It's a correct answer, that presence of organ. It's very important because we need to know, because the treatment strategy is completely different for grade 3 in comparison with grade 2 and grade 3 and grade 1. So, yeah, should we move on? Yeah, this is according to Tokyo guidelines. The grade 3 severe acute cholecystitis is defined if the patient has one of dysfunction of the following organ system. And my concerns about this, we have, if you look at this organ failure, you have so-called negative organ failure, and you have positive organ failure systems, which is respiratory, which is cardiovascular and renal dysfunction. That means that as in guidelines for the acute pancreatitis, so-called resistant organ failure, in comparison with the persistent, which means that it lasts less than 48 hours, and in the acute cholecystitis, this means that it's favorable my question is how the organ failure could be favorable. But this is favorable organ failure, which means that if patients had cardiovascular dysfunction, which recover on the fluids or within 1 or 2 hours, and also if the renal failure is very easy recoverable, then it means that it is favorable organ failure, which will be important for the grade 3 treatment in the algorithm. Grade 2 or moderate acute cholecystitis is associated with elevated leukocytes or palpable tender mass, or if the symptoms are lasting more than 72 hours, or we have on the imaging modalities, which is mainly CT or MRCP, that we have the gangrenous or pericholecystite abscess or hepatic abscess or any of the signs of the local complication. So the biggest difference between grade 2 and grade 3 is that in the grade 3 we have a systemic organ failure, and in grade 2 we have very severe but local signs of the gangrene of the gallbladder or abscess, or the very high leukocytes, but still patients is not in the organ failure. And the grade 1 or mild acute cholecystitis is that one which does not matter any of the grade 3 or grade 3. It is mainly the acute cholecystitis in the healthy patients, of course without no organ failure, mild changes in the gallbladder wall, and the risk of the surgery or any other procedure will be very low. And this is according to the Tokyo guidelines, last one, 18, how we should treat the patients with grade 1 acute cholecystitis. It's the most proper way is go directly to the early laparoscopic cholecystectomy, and the patients who is not fit for surgery, or the patients who had some problem with coagulopathy, previous treatment with the previous drug, or any signs that they cannot go immediately surgery, then we can give them antibiotics and some other fluid, painkillers, and go for the observation. But we should know that observation in those patients can lead to prolonged hospital stay, can lead to the more hospital cost. Therefore, in the grade 1, there is no doubts anymore that they are going directly, if they are fit for surgery, directly for surgery. In the grade 2 is a little bit more complicated, because the most important, we have 3 ways in these patients. One is, again, directly to the urgent laparoscopic cholecystectomy. Another is to give, of course, antibiotics and then general supportive care, and then to consider the option of delayed or elective laparoscopic cholecystectomy or urgent gallbladder drainage. But the most distinctive way between these 3 approaches is whether those centers had very highly specialized surgeon who can do early laparoscopic cholecystectomy. And it's not, as all of you know, it's not easy to declare who is surgeon who is capable to do something, and all of us, as you know, we are best skier, driver, lover, and everything as a surgeons, you know. Therefore, we need to compare our results. Therefore, we need to know who can do which type of the surgery and what can be the less harmless for our patients. Therefore, it's very important to have the centers with a high skilled and high volume centers which make this distinct difference, especially in surgery. And it's not just in complication, the difference in mortality is extremely different. So if they have capable and surgeons with experience and surgical team who can do it, then urgent laparoscopy in the patients who can hold the surgery without any comorbidities or other problem, the local findings is not contraindication anymore for the laparoscopic cholecystectomy. In the patients who are not able, then we can think about the early gallbladder drainage, whether it will be percutaneous, or as Andrea will talk, it will be endoscopic or some other type, but the first step is to go to laparoscopic surgery, but in highly specialized center. In grade 3 is much more complicated. And then we are coming that first in the grade 3, that means the patients who is in ICU with the organ failure, the patients which will be under the antibiotics and complete conservative management. And then we are coming to that no negative, just a second. Yeah. No negative predictive factors or so-called favorable organ failure, then we are going to, but again now in advanced center in patients with good performance status, they're again candidate for the early laparoscopic surgery. And this is big difference between Tokyo Guidelines 2013 and 2018, where they recommend even the early laparoscopic surgery in the patients with grade 3 acute cholecystitis. Of course, if they have poor performance status, or they have some comorbidities, they are not candidate, then they are going to urgent by the early gallbladder drainage. And again, these who have the good performance status, they are candidate for the delayed or elective surgery. Those with the poor performance status, they are going for observation. Okay. And I would like to stress once more what that means advanced laparoscopy and what that means advanced laparoscopic centers, because it means that the patient, it's not just to have the surgeons who is high volume. You need to have the high volume centers. That means that all other facilities should be experienced with some procedure. That means application of patient selection criteria. And we should know that, as I pointed several times, that surgical skills in minimally invasive surgery really vary according to different part of the country, different part of any town in the big towns. So it's, if you have hospital which is close to you, you have your friend who is surgeon, please send the patients in the hospital which have much more experience with those procedures. It doesn't mean that you are not friend of us as surgeons. So, and if we have this type of the hospitals, so these high volume centers, then, as I said before, early laparoscopic cholecystectomy is acceptable in all grades. And it's very important to select the particular pathway and all these factors according to the volume center and the surgical skills, and should be taken into the consideration. Another very important issue, whether we should do early or delay surgery. I several times pointed that it should be early or early, and what the studies say, there is no difference in post-operative complications. This is less frequent readmissions with the early surgical approach. Of course, the length of stay is shortened with early surgery, because then we combine a primary admission and secondary admissions. And there is no, which is very important, there is no difference in conversion rate between the early surgery and late surgery. And also, our patients are more happy when they finish everything within the first admission. They are not going out and worried what will happen, how it will, whether I will have new acute cholecystitis attack. So, and the patient's symptom duration has no impact of post-operative complications, which will be seen in another study. But again, I would like to stress out that do it only if you have competent surgeon and competent surgical team. And this is the study where compared in Tokyo Guidelines 2007, the idea was to take the laparoscopic cholecystectomy as soon as possible. What that means, as soon as possible. In the Tokyo Guidelines 2013, the conclusion recommendation was within the 72 hours after admission. And then this is the meta-analysis of the studies which compare early and late cholecystectomy, but also in the lower part, in the lower table, you have the studies, two studies which compared early cholecystectomy, but after 72 hours. So then, and there is the same result as the first 72 hours in highly experienced center. So that means that this distinction of 3 days, 70 hours anymore is not issue. So in Tokyo Guidelines 2018, it's that early surgery is recommended in the patients with acute cholecystitis, even though they have symptoms up to the 7 days. That means still, because mainly in a lot of surgical centers, surgeons say, If it's more than 70 hours, okay, put him on the conservative treatment. But then we realized that difference is significant in favor of the, again, less shorten of the hospital stay, less cost, and with the same complications and with the same conversion to open surgery. And also, I'm not a fan of the percutaneous drainage at all, but we need to have it time to time, and it's good bridging procedures in our patients who are non-fit for surgery, in the patients we did negative organ failure, and in the patients especially not fit for surgery, because with this bridging procedure in comparison, in those patients with laparoscopic, there is less postoperative complications. The significantly conversion rate is less, and a similar mortality and similar morbidity. But the problem is because the drainage catheter can be removed, displaced, and it causes more readmissions than if you do the laparoscopic cholecystectomy. So, in a young, fit patient, it's not an option. Why, when you can do early laparoscopic cholecystectomy? Yes, it was just old dogma that when we have scar tissue around, then it will be easier. It's not true. So we have to, and also for our friends, as you, as gastroenterologists, you have to know to whom to refer. It's not to refer to every single surgeon who is doing general surgery. Then your patients with severe acute cholecystitis will not be treated. For sure, they will receive in grade 2, he will receive gallbladder drainage percutaneously. And if this fit young patient, it's completely different approach. And at the end of the day, on the last HPV meeting, we say that acute cholecystitis, it's a very similar disease as acute appendicitis. It's acute abdominal condition. Why we will not approach it as the same as for the acute appendicitis?
We are running a little bit
and another.
We are running a little bit out of time, so
yeah,
you have to hurry
just
up
a few slides more. Laparoscopic subtotal cholecystectomy is option also. And when I started surgery, it was shame to do subtotal cholecystectomy. And you were incapable surgeon who cannot finish that very simple operation. But it's not often simple operation. And when you decided to do it, when you have bleeding within the surgical fluid and difficult anatomical identification, this is two ways how you can do it. You can do it whether to ligate the cystic duct and then to take out the part of the gallbladder and to do diathermy to do the mucosa, or you can do the suturing of the neck of the cholecyst. And it increased the complete rate of laparoscopy and safe feasible treatment options for the patients with transhepatic biliary drainage. And in conclusion, ladies and gentlemen, quick and accurate diagnosis and the staging is of paramount importance, even though for the simple disease like acute cholecystitis, early cholecystectomy whenever is possible, regardless of duration of the symptoms. Subtotal cholecystectomy is one safe and feasible option, and the surgical experience plays significant role in decision of the treatment. And the take-home message for all of you is that all of us are just one of the players of the team, and if we are behaving like this guy to think that single man can do something, then you will be surrounded by several enemies, and there is no way out, however you are experienced and strong. Thank you very much for your attention.
So thank you very much, Dejan, for this very nice presentation, and I invite Andrea Anderloni on stage for the second part of this tandem talk on the endoscopic approach. Really looking forward to it.
So thank you, Olivia and Alexander. I really enjoy this morning because I've learned a lot, and basically I realized that we have just moved in a safe area because all the topics that we have treated are topics that are very well known, and all the things that we have said are strongly supported by data, guidelines, and knowledge. But I think that when we need to bring our guidelines into the daily practice, we can have some problems. So we need to do a step forward. We are going to speak about what to do in fragile patients with acute cholecystitis. We're going to check if there are some strengths and weaknesses on the US-guided approach, and we are going to discuss possible pathway in this kind of patients. First of all, when surgery is too much for the patients, as you have recently heard, never. Well, the patient could go to the surgeon. At least this is what my surgeon always tell me. And this is basically true. Acute cholecystitis should be treated by surgeon. We can go home. Unfortunately, we face different situation nowadays. The world is changing. We have a lot of elderly patients that they have a nice life. They are very old, but they still are fit. We have a lot of patients with, oncological problems that they are fit as well. And then we can have a younger patient that in that specific moment are fragile for systemic condition. So what to do in this kind of patients? We call them fragile patients. Basically, in this kind of condition, we should ask to ourselves, patient with acute cholecystitis, is the patient frail? If he's not, just go to the theater. No worries about. If yes, maybe we need to think about what to do in that moment. And probably we need to think about how to drain the gallbladder. Because basically, here we have a systemic problem, and we need to convert a septic situation in a non-septic condition. So this could be a typical scenario. An old patient, an oncological one, that during his chemotherapy developed acute cholecystitis. The diagnosis is very well done, thanks to the help of Mariana Signoretti that told us everything about. But what should we do now? Old patient, fragile, oncological, chemotherapy, should we take him or her to the theater? We need to grade the cholecystitis, and we know how to do it, but we need also to think about the patient, so to grade the frailty of the patients. And of course, we need to understand where are we in that moment, which kind of hospital, and inside the hospital, is it Monday morning or just Saturday evening? This makes a big difference. So think about the resources, and you can think about urgent gallbladder drainage. What are the options for non-surgical approach? Percutaneous, that is very well known. Transpapillary endoscopic during an ERCP, and we have seen how to do, and this could be interesting, especially in the concomitant presence of common bile duct stones, or the more recent approach, the transluminal gallbladder drainage. Basically, the Tokyo guidelines, the revised Tokyo guidelines, tell us that in case of fragile patients, the percutaneous approach is the solution. But, and this is the new thing of the revised Tokyo guidelines, if you have the availability of endoscopic approach, you can go for it, either transpapillary or transmural. So I asked to myself, if I am in a hospital with both of the options, which one should I choose? Basically, we have some data just now, comparing the two approaches. And if you take a closer look to this very interesting meta-analysis, including more than 200 patients, you can see that as far as the adverse events is concerned, we are in favor of transluminal drainage. as well as if you analyze the hospital stay, and maybe more important, the reintervention needs or the unplanned readmission. And this is mainly due to the fact that percutaneous drainage has a lot of problems, pain for the patients, occlusion, misdeployment. This is how we can drain the gallbladder by EUS just now. Everything changed when we started being familiar with the lamps, especially with the hot lamps that allow us to perform a gallbladder drainage under direct EUS evaluation. This is one of the first gallbladder that I have drained 8 years ago, and you can pretty much realize how easy it is and how controlled it could be. Moreover, we are performing it just by EUS images, and this is another advantage. After the deployment of the second flange, you can also realize that this nice and wide stent allow you also to do few things more if you need it, because the lumen is quite wide. So I am now in a situation in which I can do basically whatever I want: surgical approach, percutaneous approach, transpapillary approach, or transmural approach. But between the three non-surgical approach, I need to know what to do, especially if I am in a hospital that allow me to do everything. And basically, in this nice evaluation comparing the three possibilities, they have shown that the transmural drainage could be the first choice. And the main reason is that with a high clinical success, it has a low adverse events. Also, the percutaneous drainage has a high clinical success, is fully available, but as we have mentioned, it has quite high complication. Not very heavy, but very nasty because it needs the patient to come back. And of course, the transpapillary is quite complex. It has not a high, let's say, clinical success or better technical success. It's quite difficult, and you need to perform ERCP as well. So in the past, in a fragile patient, the only possibility, non-surgical approach, was the percutaneous, and we didn't have any other option. But nowadays, we have also this option, and I want you to keep this on mind. Which one should I prefer? We have already told all the staff, surgery should be the first choice, but if the patient is fragile, let's analyze percutaneous with all the nice things about the percutaneous or US-guided drainage. Here, the only way to choose is to think about the local availability. But maybe, in order to overcome the problem, we need to think in another way. Probably these two approaches are not one against the other, but they should be together. Why don't we think about a nice solution? That is what we call the conversion. As you know, percutaneous approach is pretty available everywhere. It's quite easy, and it can allow you to wait and to send the patient to an expert center in order to perform the conversion. The conversion allows you to fill the gallbladder from the percutaneous drainage and to do the EUS gallbladder drainage approach. So, Maria, see that? 10 minutes, finished. But I want to steal 20 more seconds, because one of the main issue of EUS approach is also the altered anatomy, but sometimes you can perform nice picture also in the altered anatomy. Another issue is the a lot of stones inside the gallbladder that doesn't allow you to have a beautiful EUS picture, but with some tricks, that means fill the gallbladder by a needle, you can fill the gallbladder, do the transluminal drainage, and after this you can have also a nice and clear access to the bile duct that could be very difficult to analyze in an altered anatomy. And this is a nice picture to show you that now you have different possibility to do. In this case, we just stopped because it was more than enough. Thank you very much.
Andrea, I had given you already more than 5 minutes extra time, so you could go on more than 3 minutes, because I know that it's always brilliant what you showed. But nevertheless, I think we should have our surgeon on the stage and discuss the points together. Maybe there's already one question until we are complete on the podium. Do you combine the lamps with a plastic stand, like we do sometimes in necrosis, to let it stay open, that if your foot gets in, that you don't have occlusion? Or is it a seldom thing you do, that you combine the lamps when it's already in place with a double pigtail, for example?
I don't know if I understood well. You are asking me if you need to place a plastic stand in order to avoid the food impaction and stuff like that. We do not have too many data, as I told you at the beginning. I don't do it routinely, but I try to understand, not only the anatomy, but also where I put the stand. Because sometimes we don't have a good shot wherever we want, and we need to place the stand nearby the pylorus or in an area where the food could be easily impacted. So this could be a nice idea. The other problem, for a reason time, I didn't touch it, but I would like to stress about the grade of the cholecystitis, because the same problem that the surgeon has, it's the problem that we can have. Sometimes the surgeon opens the patient and the gallbladder is just disappeared. We can have also this kind of stuff in our approach. So it's very, very important to analyze the CT scan before and to understand properly the vitality of the gallbladder. We are trying to understand better with the contrast agent, with the Doppler, in order to see if the wall of the gallbladder is still elastic, in order to have a good outcome.
So there are a lot of, I think, important questions coming on the same issue. I think we are completely agreed that it's a teamwork. So we are not the solution, and we are not heading for the next cardiology TAVI procedure. We still team up with our surgeons. And the question is, if the patient improves, how to go on? Do you take the lamps out, or is it direct surgery? Or the other question also, if the patient does not improve and does not become a non-surgical patient, how to go on? Let the lamps stay in place or take it out? What is your strategy?
So this is a very nice question that allows me to make another question to my friend. So first of all, what to do if the patient improves? Let's say that the patient improves. Otherwise, I would not go for the treatment. And usually you have the improvement in the first 24 hours. If you drain the gallbladder and the patient doesn't change in 24 hours, there is a problem. The other problem is if the patient goes well after 24 hours and after 48 start again having problem. This is something that happened to me. The patient did well, and after 48 hours, he started again having sepsis, stuff like that, and it was because the gallbladder, not occlusion, but the gallbladder was already dead, and so we weren't able to perform properly. But if it goes well, let's say, if the patient is an old patient, I would say just leave it. I'm not going to remove the stent, and I don't want to see the patient anymore. There is another school that prefer to remove the lamps between 6 and 9 months after the procedure. The question is, if the patient goes well and he comes out from the fragile condition. So it could be a good candidate for surgery. Dear friend, do you like to have a lumps in between your situation or not? And if you like it, do you prefer to have the lumps just from the stomach or from the duodenum?
Well, yeah. First, I don't like to have the lump during my lap chole. That's generally. Yeah. If you can do it via stomach, it's much easier. Because for me, it's much easier to suture the stomach than duodenum. Stomach is very thankful organ for suturing. You have very strong walls, so you can suture it very easy. Duodenum is not like that. And maybe the option is to take out the lump, to wait to close, because for the surgeon, that hole in duodenum is always a problem, especially with scarring around. When you have to suture it, then it's not secure as it's lap chole. So it will be better to take out the lump, to wait to make the scarring, because the hole will completely close, and then to do just lap chole, to avoid suturing duodenum or stomach or everything.
So this is very interesting. And shall we say that whenever you start performing this, you need to speak with your hospital, surgery, of course, surgeon, of course, because someone could prefer some approach or the other, and you need to have the surgeon on your side, because the team building that you have shown, it's scaring me, because I don't like that kind of
just one.
often, just like one with the big football player. Anyway, so between the transgastric approach and the transduodenal, we should prefer the transgastric approach. I agree completely. And this is quite nice. If you need to bring the patient to the theater because he's getting better, you can speak with your surgeon in order to adjust the situation. You can remove the lumps, wait until it closes. We can close as well with some tricks and see what's going on. Very nice.
Would love to have this going on for the next couple of hours, but nevertheless, any questions from the audience?
Hello. Hi, I'm Dr. Noor. Thank you all for your amazing lecture. I have a question. We know you talked about calculus, cholecystitis, which you can sometimes have no hope for the patient because he's like metastatic. So how about acalculus, cholecystitis in the ICU? When we have such a patient, he cannot go to the surgery because he's too sick for a couple at least of days and weeks. Can we use this lamp as a bridging for acalculus, cholecystitis, which I face a lot of referral in my center? So we know this patient most likely will improve. So should go with endoscopic versus percutaneous, and which was preferred for you and the surgeon after 1 week? Or if, let's say, after 2 or 3 weeks, he will have surgery to do the measurement.
I like this question very much, so I will ask for 30 more minutes to discuss. Basically, this is a very interesting situation, very common as well. I don't care too much about calculus or acalculus. I care about cholecystitis. I care about the patient, I care about the situation that could be a systemic situation. That kind of patient is the third patient that I show you in the first slide. We have elderly patients, we have oncological patients, and then we have patients that they are living in a specific, very critical condition, like post-cardiac surgery or stuff like that in the ICU. In that kind of patient, I will strongly recommend the EUS approach. You can perform it directly in the bed, at the bed of the patients, because you can move your EUS stuff over there. You don't need necessarily the RX machine, although I strongly suggest, if you can, to perform it under the X-ray evaluation, because if you have any kind of complication, it could be very helpful. But otherwise, you can easily perform the procedure on the bed of the patient. And as I told you, the patient in less than 24 hours gets better. Then, after the recovery of the patient, you can discuss with the surgeon in order to bring him to the theater. I don't know if I answered to your question.